Friends, now we'll see a very important topic of burns. Many times a few questions are asked on burns. So burn involves various stages such as pathophysiology, then management and then complications. And we have got various types of burns. So now we'll see how to measure burns. So there is rule of 9. So it is used to measure the total body surface area burn in adults. By adding together the affected areas, the percentage of total body surface area that is burned can be calculated. So roughly this is divided into 9. So 9 for right upper limb, then 9 for left upper limb, then 9 for head and neck, then we have got 18 for front and abdomen, then 18 for back, then we have got 18 each for each lower limbs, and perineum and genitalia make 1%. So overall it is 100%. So this differs in some way in infants. So we'll see now how it differs in infants. So generally it takes 6 hours for skin maintained at 44 degrees to suffer irreversible changes. But a surface temperature of 70 degrees for 1 second is all that is needed to produce epidermal destruction. So a very short time span is required to cause skin burns. Then next method of estimating smaller burns is to using palm size of the patient. Open hand including the palm and fingers, so which is approximately 1% of total burn surface or 1% of total body surface area. Children have a relatively larger portion of body surface area in head and neck, which is compensated by a relatively smaller surface area in lower extremities. So according to age, they have got various percentage of burns which is contributed by head, surface areas contributed by head and neck. So you should go through this very carefully, because many times questions have been asked, infant of this years of age has got burns over head and neck, what will be the percentage? So infants have 21% of total body surface area in head and neck and 13% in each leg. See how it differs. In adults it was 9%, but in children or infants it is 21%. Or in leg adults it was 18% in each lower extremity, but in children it is 13%. So it differs accordingly. So according to percentage of heads, here is the chart. So at birth it is 19% of the head. Then at 1 year it goes to 17%. At 5 years it is 13%, and in adults it is 7%. You have to add 2% to each of them to make it head and neck. So 2% is for neck. So you should go through this chart very carefully, because you may be asked questions according to age. Next we'll go assessment of the depth of burns. So the thermal injury, the depth of the burn depends on the temperature of burning agent, the mode of transmission of the heat, and duration of contact. Burn causes coagulative necrosis of epidermis and underlying tissues. It is divided into 3 zones, that is zone of coagulation, zone of stasis, and zone of hyperemia. So please go through these zones very carefully, because there are distinct changes occurring in each zone. So you may be asked MCQ questions based on description of each zones, and you are asked to identify which of these zones is. So now we'll see zone of coagulation. The volume injured most severely in the center of the wound is the zone of coagulation. This is the area of necrosis where the cells have been disrupted. So it is center of the attack of the burn agent. Next we have zone of stasis. So next to the zone of coagulation we have got zone of stasis. Outside the zone of coagulation is the zone of stasis. The zone of stasis is ischemic but potentially salvageable. Depending on the wound environment, it can either survive or progress to coagulative necrosis. So it can be recovering well with epithelialization, or it can undergo full thickness necrosis. The zone of stasis is associated with vascular damage and vascular leakage. So this is a borderline zone which can improve or which can deteriorate. Next we have got zone of hyperemia. So beyond the zone of stasis lies the zone of hyperemia. This area is characterized by minimal cell injury but with vasodilatation due to neighboring inflammation induced mediators. This region contains clearly viable tissue from which the healing process begins and is generally not at risk for further necrosis. So you may be asked questions on various parts of this talk, because you may be asked which of the following zones is not at risk for further necrosis. So it is clearly zone of hyperemia. Then we have got zone of stasis. So there can be necrosis or there may not be necrosis. And then zone of coagulation is definitely necrotic zone. So please understand the difference between each of these zones. In practice, attempting wound care and careful fluid resuscitation may salvage the zone of stasis, and it will prevent superficial injury from becoming full thickness. Now we classify burns according to the depth. So first degree burns where injury is localized to epidermis. So here we can depict as epidermis up to this level. Below this there will be dermis. Next there will be fat. So up this and up to this level is dermis. Then there will be fat depicted by yellow zone, and below yellow zone is muscle. So we have got first degree burns which is injury localized to epidermis. So this up to this level, this is called as first degree burns. Next we have got second degree. Next to the first degree starts second degree. So second degree burns are divided into superficial and deep burns. So superficial second degree burns are epidermis and superficial part of dermis. So these are called as superficial second degree burns. Next we have got deep second degree burns, so in which the burn extends in the dermis. So this is how it goes on in depth, increasing with the depth. Next we have got third degree burns, that is full thickness injury through epidermis, dermis and up to subcutaneous fat. So whenever there is exposure or burn injury extending up to subcutaneous fat, it is third degree burns. Below that, if the muscle, bone or fascia if they are exposed, then it is called as fourth degree burns. So you should go through these burns charts very carefully. Burn is a tissue injury from thermal, that is heat or cold, application or from absorption of physical energy or chemical contact. Each type has its own distinct features and management problems. So now we'll see various burn agents and how they cause burn injuries. Now we'll see scalds. They are produced by hot water. Since the temperature of hot water and steam is constant, the severity of injury depends on duration of contact. Those who are not able to protect themselves are more vulnerable. So very young and very old are mainly affected. They usually result in second degree burns. Immersion in boiling water or prolonged exposure to steam can occur as industrial accident. So scalds, they are generally in second degree burns. So you can see they are generally second degree superficial burns. So there will be blistering. So you may be asked a question, in which of the following degree burns blister is common? So they are in second degree. Next we have got fat burns. So they are caused by cooking fat or cooking oil. It has got much higher temperature, that is 180 degrees. So fat cools down slowly and hence it will cause more deeper burns. It usually causes full thickness skin loss. So fat burns, they cause full thickness skin loss. So generally third degree burns and onwards, they are caused by fat. Next we have got flame burns. So they have varied etiology. House fires and all clothing fires, spill of petrol on skin or butane gas fire. They usually occur in confined spaces, but they may be associated with inhalation injury. Generally they cause deep burns. Next we have got electrical burns. It is a passage of electrical current through the tissue which will cause heat in the generation in the tissues and leading to the cellular damage. Heat produced is proportional to resistance of the tissues, duration of the contact and square of the current. Since bone is a poor conductor of current, it becomes very hot and causes secondary damage to the nearby tissues. So current going through bone will heat the tissues or muscles, they are in close proximity of the bone. Low voltage current of less than 1000 volts such as domestic supply causes significant contact wound and may induce cardiac arrest but no deep tissue damage. So you should go through this low voltage current can cause cardiac arrest but no deep tissue damage. High voltage burns, that is contact with more than 1000 volts, can cause damage by two mechanisms. The flash from arc can give rise to burning of the clothes and can cause entry and exit wounds. With current transmission through body, it can cause respiratory and cardiac arrest. Now we'll see cold injuries. This type of injury can occur in mountain region, though it can also occur from industrial accidents due to spill of liquid nitrogen or similar substances. There is acute cellular damage which can result in partial or full thickness burns. Severe cooling can freeze the tissue and can result in ice formation, resulting in tissue damage. Prolonged exposure to cold can result in frostbite due to an element of ischemia due to vasoconstriction. Next we have got friction burns. Tissue damage in this type of burns is due to combination of heat and abrasion. Generally it will result in superficial wound that may progress to full thickness skin loss. They may be associated with deglowing of the limb because of the mechanical forces. They are best treated with early debridement and skin grafting. So choice of treatment for friction burns is early debridement and skin grafting. Next we have got burns due to ionizing radiation. X-ray irradiation may lead to tissue necrosis. It is rare where industrial safety and precautions are taken. Tissue necrosis may take long time to develop. The more significant is the cumulative effect of the radiation, which may induce skin cancers and several other tumors. Next we have got burns which are caused due to spillage of chemicals. Numerous chemicals in industrial and domestic situation can cause burns. Tissue damage depends on the strength, quality, quantity and duration of contact. Chemicals cause local coagulation of the protein and necrosis, but some of them they also have systemic effects due to absorption. So chemical burns can cause coagulation and necrosis. So this is to be noted. Harmful effect will continue until the chemical is diluted and neutralized. Hence the most important initial treatment is dilution with running water. Now we'll see effects of burns. So they can be under local effects, regional effects and systemic effects. In the local effects we have got tissue damage due to heating and due to which cells rupture and cause necrosis. Collagen is denatured and peripheral circulation is damaged. Capillaries they get thrombosed and capillary permeability is increased, leading to edema and leakage of serous fluid. Next is the inflammation. There is marked and immediate inflammatory response due to neurovascular response. It may range from erythema to prolonged inflammatory response. Ultimately, there is desloughing of damaged tissue which may take up to 3 weeks. Next is infection. So damaged tissues act as nidus for infection. The burn wound is almost invariably colonized with microorganisms in 24 to 48 hours, which may cause local or regional infection. So practically burn wounds are sterile up to 48 hours. So this is a very important point which may be asked as question. Bacteremia and septicemia resulting afterwards can be fatal. Next we have got regional effects of burns. They are in circulation. In case of burning of extremities, the circulation of the limb may be compromised. This can be caused by direct damage to blood vessels, which is rare, seen in electrical burns, or due to compression of vessels because of edematous tissues or compartment syndrome following ischia formation. Next we have got systemic effects of the burn. The most and prominent is fluid loss. Fluid may be lost from damaged capillaries either by visible external loss or internally in form of tissue edema. It can result in hypovolemia. Prevention of hypovolemia is most important factor in early resuscitation of burn. Effective replacement of fluid will minimize the risk of complication. So in fluid loss, the total body volume generally remains unchanged. It is the leakage that is causing loss in the intravascular capillary circulation. Next we have got multiple organ failure. There may be progressive failure of renal, hepatic function along with the cardiac failure. Probably the cause may be fluid loss or toxemia from the infection or uncontrolled overcorrection of fluid or inflammatory sepsis leading to all these systemic multi-organ failure changes. Next we have got inhalation injury. This type of injury occurs in those who are trapped in closed spaces associated with head and neck burns. Inhalation of hot gases causes thermal burns to the upper respiratory tract. Poisonous gases like carbon monoxide and hydrogen cyanide may be inhaled. So you may be asked which of the following gases are mostly responsible for inhalation injury. Next we have got systemic complications in form of Curling's ulcer, which are gastric or duodenal ulcer resulting in hematemesis. Immunosuppression can lead to the increased risk to septic complication. Catabolic response to the trauma with severe weight loss can be there over a period of time. There can be non-specific complications like catheter infection, deep vein thrombosis or pulmonary embolism. Now we'll see the management of burns patient. So it is similar to resuscitation of any trauma patient. You have to secure airway, you have to monitor vital signs, you have to remove clothes, obtain body weight, and you have to take patient away from the source of injury. You have to start with large bore IV lines and you have to start infusing Ringer's lactate solution. Here normal saline is not preferred because of hyperchloremia that may be associated with more of NaCl infusion. You have to estimate the extent and depth of burn, calculate fluid requirement. You have to insert Foley's. You can insert Ryle's tube if total percentage area of burn is more than 25%. So you should note that. You have to collect sample for investigations like serum electrolytes, blood group and cross matching. Tetanus toxoid along with tetanus immunoglobulin can be given. So many times a patient comes to you with burns. What are the criteria for admission? You should go through these criteria very carefully because you may be given a clinical scenario and you are asked whether to admit or not to admit this patient, or which of the following is not a criteria for admission to the hospital. Like that the question can be framed on this. So adults with partial thickness of burns of more than 15% of total body surface area. So this is the indication for hospital admission. Children with partial thickness burns of more than 10% of total body surface area. Next we have got any patient with full thickness burns of more than 2%. So you should not make the difference that partial thickness burns of more than 15%, full thickness burns of more than 2%. Then inhalation injury with or without cutaneous burns. Burns of the face, of both hands or both feet or of the perineum region are indications for admission. All electrical burns should be admitted irrespective of whether they have caused damage or not. Suspected child abuse or neglect should be admitted. High risk patients, that is aged less than 3 years or aged more than 65 years, and patients with pre-existing medical problems should be admitted. So you should go through these admission criteria very carefully. Next we have got the fluid resuscitation. So many options are available: crystalloids, hypertonic lactated saline solution or colloid containing solutions. Most commonly used formula is Parkland's formula. However, any formula is a rough guideline for resuscitation. It is extremely important to monitor patient's response to resuscitation and adjust the rate of administration of the fluid rather than to adhere to formula blindly. So you have to adjust the administration rate according to urine output and patient's vitals. How do you calculate fluid requirement? For the first 24 hours, fluid is given as follows. You have to give Ringer lactate solution. In adults, it is 4 ml per kg per percent of burns. In children, it is 4 ml per kg per percent of burns, plus you have to add basic fluid requirement. So this is the change in children. So you may be asked to calculate fluid requirement in first 24 hours. How do you infuse? The rate of infusion, it is 50% during the first 8 hours, 25% of the total requirement in next 8 hours, and remaining 25% in last 8 hours. So this is how you calculate. Generally, colloids are not given in first 24 hours. This is because the capillaries are too much leaky and they will eventually cause leakage of macromolecules in circulation. So out of circulation they will leak into subcutaneous space. So they won't be causing of much use. Next 24 hours you have to give maintenance fluid in form of 5% dextrose with 0.45% normal saline with 20 milliequivalents of potassium chloride per liter. So colloids can be given after 24 hours. Albumin is the best colloid which can be used. So you may be asked after 24 hours which of the following colloids is the best. They may give you options like dextran, albumin and other colloids. So albumin is the best. The time for calculation of the fluid requirement begins from the time of burns and not from the time of admission to the hospital or of the time of starting resuscitation. So when you admit this patient, they should be resuscitated initially for the time they were not given fluid. Other formulas are Evans formula, Brooks formula, modified Brooke formula, and hypertonic saline formula. How to monitor resuscitation? The following parameters should be measured regularly and treatment should be altered to achieve goals like good sensorium, vital signs should be maintained according to the systolic BP more than 120 millimeters of mercury, tachycardia less than 120 per minute, core temperature of body should be between 37 to 39 degrees and respiratory rate between 12 to 20 per minute. Next, urine output is a good indicator of monitoring of the hydration. So if you are asked which of the following is the best indicator for patients' adequate resuscitation, you may be given pulse, blood pressure, everything, but it is urine output, that is 0.5 to 1 ml per kg per hour in children and 30 to 50 ml per hour in adults. This is the adequate goal that should be achieved after resuscitation after burns patient. Central venous pressure should be maintained between 5 to 10 centimeters of water. You should monitor blood sugars. Basal investigations in form of electrolytes, blood urea nitrogen, serum creatinine should be sent along with serum albumin. Reasons for inadequate resuscitation are underestimation of burn size, inhalation injuries, deep burns or electrical burns, delayed fluid resuscitation, myocardial depression factor of severe burns. So these are reasons for inadequate resuscitation. Next, how do you manage a burn patient in wards? Initial wound care in the form of cleaning of the wound with bland soap and water and removal of all dirt and devitalized tissues is very important. If the burn is over large area, debridement can be done under anesthesia. Next, we can apply a topical antimicrobial agents. Topical antibiotics in the form of silver sulfadiazine cream should be applied over burn area. Silver sulfadiazine is useful, but many times it is unable to penetrate the ischium. Mefenide acetate, another agent which can penetrate the ischium. So if you are asked question which of the following agents can penetrate ischium, it is mefenide acetate. Whether to do dressing open or after closing, this is very important. Open exposure dressing will allow the continuous observation. It will early diagnosis of the complications, good mobility of the patient, and it is easy and painless. So many times you may be asked which of the following dressings is important. But open dressing has a disadvantage in form of cross-contamination. So generally the open dressings are not advocated. Closed or occlusion dressings which are better. An occlusion dressing is applied over the agent and it is changed twice daily. Advantages are less pain, less heat loss and less cross-contamination. Closed method is generally preferred except for the face and head where exposure method is preferred. Moist dressings are avoided. Generally, the dressings which are applied after soaking in saline or betadine solution, povidone iodine solution are avoided. Next, you go to monitor this patient. Twice daily observation with inspection and palpation of the ischium to look for any collection, deroofing and drainage and escharotomy if necessary. So ischium should be monitored. The peripheral limb circulation should be monitored regularly. Now we'll see escharotomies. Ischar is a dead, dry and shriveled dermis that is still adherent to subcutaneous tissue because of coagulative necrosis of burns. So ischar is formed after dermis. So it is seen in second degree or deep dermal burns onwards. Escharotomy is surgical sectioning of the ischar to restore normal circulation and movement of underlying tissue. Why escharotomy? Ischar is inelastic tissue. In case of extremities, after burns, there is edema formation. Ischar is inelastic and edema below it will result in increase in the pressure of the compartment. The increased compartmental pressure may compromise blood circulation of the limb which can lead to gangrene. What are the indications for escharotomy? So you may be asked which of the following will form indication to divide ischar. Clinically, pain, paresthesia, absent peripheral pulses, cyanosis and impaired capillary return will form indication for escharotomy. Minimal to absent blood flow on Doppler with subischial pressure of more than 30 millimeters of mercury will form indication. In case of chest burns, respiratory distress in circumferential burns of chest will form indication of escharotomy. For prevention of infection, surgically you can debride dead tissue, you can excise tangentially and even you can do amputation, especially in cases of electrical burns. Medically, to prevent infection, you can give antibiotics, local or systemic. Vaccination against tetanus should be carried. For closure of the wounds, you can do split skin grafting, and temporary biological dressings can be applied like xenograft, cadaver graft or amnion. So split skin grafting can be done for second degree deep dermal burns or dermal burns. But the choice of treatment for superficial first degree burns is covering with the soak or moist solutions. For second degree superficial burns, you can cover with any of the artificial membranes like collagen. We have got skin substitutes for them. These are collagen and dermal analog. Then we have got C-elastic epidermal analog or composite analog. Nowadays, cultured epidermal cell membranes are available. What are the advantages of closure? Closing will prevent loss of red blood cells, water, heat, and most important, proteins. So, why do you close? If you are given various options, to prevent loss of proteins is the prime amongst them. It will protect the wound and defer tissues. It will avoid infection. It will promote granulation formation. Closure will reduce the pain and it will promote mobilization. Now we will see specific management according to degree of burns. First degree burns, the wounds are minor with minimal loss of barrier function. These wounds require no dressing and they are treated with topical soaks to reduce pain. Oral non-steroidal anti-inflammatory drugs can be given for pain control. Second degree burn wounds can be treated with daily dressings or topical antibiotics, cotton gauze and elastic wraps. Alternatively, the wounds can be treated with temporary biologic or synthetic covering to close the wound. Deep second degree burns and third degree burns are treated by excision and grafting. So, this is the choice of treatment for deep second degree and third degree burns is excision and grafting. So, many times you are asked question, what is the choice of treatment for second degree deep or third degree burns? Or alternatively, you may be asked question like excision grafting is treatment of choice in which degree burns. So, it is second degree and third degree burns. Initially, the dressing is used to check bacterial proliferation and it will provide occlusion until surgery is done. Now we are to calculate the calorie requirement for burns patient. They are given by Curary formula. In adults, it is calculated as 25 kilocalories per kg body weight of patient plus 40 kilocalorie per percentage of burns area. So you have to add basic requirement plus additional requirement for burns. So they are 40 kilocalorie per percent area of burns. In children, they are calculated as 35 kilocalorie per kilogram of body weight plus 60 kilocalorie per total surface area burn. So 60 into total percentage of burns plus additionally 30 kilocalorie per kg. Protein requirements after major burns, they will increase up to 2 to 3 times of the normal, that is 1.6 to 3.2 grams of protein per kg body weight. Vitamins and trace minerals should be supplemented. Orally, for patients who can eat, they can be provided orally. Burns more than 15% of total surface area, they will require nutritional support. High protein and high calorie diet should be given. Enteral nutrition is better. So enteral nutrition can be given through Ryle's tube. The tube is positioned by fluoroscopic guidance. Enteral nutrition is indicated in burns more than 20% area where dietary requirement they do not meet calorie and protein requirement when patients they cannot consume because they are not willing or they are unconscious. Parenteral nutrition is indicated in cases of inadequate enteral nutrition. It can be given through peripheral veins. So 10% dextrose along with amino acid and lipid solutions can be given. It can be given through central vein when peripheral veins are not adequate. Central veins should be changed after 72 hours. Friends, now we'll see complications in burns. So we have got early complications in form of burn wound sepsis. They should be suspected when there is focal dark red or brown colored issue, conversion of partial thickness burn to full thickness burns, rapidly spreading subcutaneous edema. So all these factors, they should be indicative of spreading of infection. Pseudomonas is the most common infection in burn patients. It has replaced streptococci and staphylococci because of availability of good antibiotics. So if you are asked question which of the following infection it is most common, it is Pseudomonas. Next, how do you treat the infection? Surgically debridement, local and systemic antibiotics according to sensitivity. Once the infection is under control, there is good granulation of covering of the wound and then they should be grafted. Next, we can have complication in form of bronchopneumonia and suppurative thrombophlebitis due to intravenous cannulation. GIT complications in form of paralytic ileus are seen in percentage area of 25% burns. So, whenever you got percent area burn more than 25%, these patients should be kept nil by mouth till their bowel functions return. Paralytic ileus is treated with electrolyte imbalance correction and nasogastric decompression. Curling ulcers, they occur due to ischemia. They are prevented by giving pantoprazole or ranitidine along with antacids and sucralfate. Next, other complications are acalculous cholecystitis, colonic pseudo-obstruction, acute pancreatitis, ischemic endocarditis, and superior mesenteric artery syndrome. Iatrogenic pneumothorax in form of central venous line catheter insertion can be there. Pulmonary edema is seen where overfluid replacement is done. Acute renal failure is common due to decreased renal blood flow or myoglobin breakdown or nephrotoxic drugs. Myoglobin breakdown is the commonest complication seen in electrical burns. Myocardial ischemia and infarction can also be an acute emergency. Now we'll see late complications. Hypertrophic scars, keloids and contractures are seen in deep burns. They can be prevented by physiotherapy and pressure garments. Next, we have got hyperpigmentation or carcinoma arising from the burn scar along with heterotrophic bone formation in a thick scar. Now we'll see inhalation burns. They are suspected when there is history of close space injury, facial burns, and patient has got carbonaceous sputum along with respiratory distress. Patient may have stridor or wheezing. They are confirmed by X-ray chest, blood gas analysis or carboxyhemoglobin assessment or with xenon 131 scan of lungs. Bronchoscopy is one more method to confirm inhalation burns. Establishment of airway by intubation or even tracheostomy is the first priority. 100% oxygen is started, that is 4 liters per minute, till carboxyhemoglobin report comes to normal. Patients may require ventilatory support along with vigorous chest physiotherapy and avoidance of infection. Now we'll see electrical burns. It is burned due to contact or passage of electrical current to body. The body will offer resistance to the flow of currents. So heat will be generated inversely proportional to the cross-section area of body, hence limbs are severely affected. Body acts as a volume conductor and hence the damage is maximum at the site of contact and at the site of arcing of the current. Current can directly damage tissues. Tetanus that will causing after current passage of the body will hamper the movement of the patient from the source. Associated thermal burn and trauma can aggravate burn injury. Factors determining the severity of burns in case of electrical currents are the strength of the current, the type of current. The alternating current is more dangerous because it induces ventricular fibrillation. So if you are asked which of the following electrical abnormalities are common or which of the following cardiac arrhythmias are common in cases of electrical injury, it is ventricular fibrillation. Type of tissue and resistance offered by tissue will also cause the factor which will determine the electrical burn injury. Duration of the contact and whether the path of current, that is if goes through vital organ, that is also very important. So duration of contact and whether the path of the current that is involving or not major organ or vital organ, it is also important. The immediate complications are neurological deficit in form of acute transverse myelitis, hemiplegia, quadriplegia or peripheral nerve palsy. Visceral damage in form of liver and pancreatic necrosis, intestinal perforation can be there after electrical injury. Late complications in form of cataract formation, cholelithiasis, focal neurological deficit or hemorrhage from damaged blood vessels can be there. Electrocardiogram should be done to rule out arrhythmias or infarction. Other investigations, they include their arterial blood gas, serum electrolytes, blood urea nitrogen and blood sugar. Sodium bicarbonate is given to alkalinize the urine to prevent tubular damage. we have noted that myoglobinuria leading to the acute renal failure is the most common cause of renal failure in electrical burns. So sodium, that is called as forced alkaline diuresis. So dextrose along with soda bicarb along with mannitol solution is used to give forced alkaline diuresis. More fluid is required during resuscitation as the extent of burns is always underestimated in cases of electrical burns. Other management in form of tetanus toxin and antibiotics, they remain as regular. The electrical burn wounds may require debridement and management along usual guidelines. Escharotomy should be done if indicated. Careful observation is required for prevention of complications in case of electrical burns because the damage to the muscles is not visible from external surface. So all these patients should be monitored for their peripheral pulses and complications as soon as they occur. So friends, in this lecture of burns, we have covered pathophysiology of the burns, how to measure percentage of burns, what are various types of burns caused by various agents, how to manage burns in acute setting, how to prevent the complications of the burns, and how to identify burns. We have also seen in detail what are the complications after electrical burns. Thank you.